virtual tumor board. And today the topic for the virtual tumor board is dealing with gastrointestinal stromal tumors, which is an interesting subject following the discovery of tyrosine kinase inhibitors. And I'm sure there has been a lot of progress in this field, which through cases, Dr. Rajneesh from Sanjay Gandhi Postgraduate Institute has been kind enough to share some cases, which will highlight some of the practical problems that we face in the decision making for these cases. And we have a illustrious panel headed by Dr. Rajneesh, Dr. Vikram from Tata, and Dr. Rajesh Panwar from AIIMS New Delhi. So first, all the delegates who joined either of the links to keep themselves muted and keep the video also down, and put their queries in the chat box. That will be taken up after the discussion session starts, and we hope to answer all the queries. So over to you, Rajneesh.
Thank you so much, Sujoy. I hope I'm audible to everybody, and a very good evening. So we have illustrious panel here. I think Dr. Sujoy has already made a note of who they are. We have surgeons, Professor Vikram Chaudhary from TMH, Professor Rajesh Panwar from AIIMS New Delhi. We have a pathologist who's Dean of AIIMS Raebareli, Professor Neeraj Kumari. We have a medical oncologist who's from BLK Max in Delhi, Professor Satya Sadan Sarangi. And we have a nuclear medicine specialist, Professor Manish Ora from SGPGI. So can I share my screen?
Yes, please.
Am I visible?
Yes, visible.
Yes.
Please put it on slideshow mode.
Okay, so we have our younger colleague here, Dr. Kush Parekh from my own institution, who will be presenting the cases, and then we'll go on to the discussion part of it. Dr. Kush, why don't you start, and then we'll catch on.
Yes, sir. First case, sir. So we have a 53-year-old gentleman who's a known diabetic presenting to us with gradually progressive dysphagia since 6 months with a weight loss of 3 kgs over the past 6 months, no anorexia or any GI bleed. On examination, he was obese with a BMI of 32 and examination revealed a small umbilical hernia. The rest of the examination was normal. His blood was subsequently evaluated to upper GI endoscopy, which is up for discussion.
So the endoscopy showed us a lesion at the G junction, and this is a retroflex view, as you can see. The lesion is submucosal, as the mucosa is normal, and it is surrounding about half the circumference of the G junction. So what do you think, Rajesh, Vikram, how would you want to go from here?
So endoscopy here shows a submucosal kind of lesion. So we need to evaluate it further. So you can do a endoscopic ultrasound to see which layer it is arising from. And then based on the endoscopic findings, we can evaluate further. Size of the lesion seems to be around 2 to 3 centimeters. So differentials here would be either a leiomyoma or a gastric or a GIST. GIST will be more likely because it's in stomach. If it was in esophagus above the junction, then leiomyoma would have been more likely. So the evaluation here would be to know which layer the tumor is arising from, what is the size of the lesion, and then based on that, we can do a cross-sectional imaging to further classify it.
Okay, so we have an endoscopic ultrasound which confirms what you said. Looks like a submucosal lesion, possibly, as you said, a GIST or a leiomyoma. Do you think CT at the same time would be required, or do you think it would be required only after the US?
If you are doing endoscopy and you can do the US at the same time, then it's okay. But otherwise, you can do a CT because that will help in planning the treatment. And US is required only if it is located at unusual, or you are planning to do some endoscopic therapy, or you want to do a biopsy, or enucleation is being planned if you can think it is a leiomyoma. Otherwise, US is not a must.
So Rajesh, I mean, the lesion obviously is quite simple and straightforward to diagnose. So what are the anatomical and surgical issues you want to get answered by getting this thing done, imaging done, further imaging done?
It is very close to the G junction. That is the important part here.
Okay,
So
great.
it has quite challenges because resection is not going to be straightforward. If the lesion is located in the greater curvature of the stomach, it is easy to do a stapled resection. But if it is located in the lesser curvature higher up near the G junction, then obviously there is a chance of narrowing at the G junction. And you need imaging for further planning. The size of the lesion is important, and whether you would be able to get a margin or not. And then it will help you plan whether local resection would be sufficient, or you will need a more complex procedure like a total gastrectomy or proximal
Great.
gastrectomy.
So I think Manish, can you just give us an idea what this is? Then we'll go back to Vikram and Rajesh and see what planning is. Manish, are you around?
Yes, sir. Basically, we need a triple phase CT scan or maybe dual phase CT scan will be sufficient. The most important thing is to have a well-distended stomach, or if you are taking rectum position, then you have to take a good negative contrast also, because you will be able to see at least how much margins are involved. Here you can clearly see what is less than 5 centimeter in size. It usually follow all the rules of typical GIST. So it will be intraluminal or maybe extraluminal, and it is homogeneously enhancing, and mucosa appear to be smooth. But if the size increases, then these characteristics are being lost. That means there may be some central areas of necrosis, and it may even show the different layers of bleed if it is bleeding, and there may be some mucosal ulceration also. Here we can clearly see it is around 5 centimeter mass, homogeneously enhancing, and it is in the G junction. No lymph node, nothing is there. So again, it is in favor of the GIST. And the important thing is that you can differentiate from here that it can be a soft tissue sarcoma also. So DD will be this soft tissue tumors and GIST.
Yeah, so that's a good thing. Actually, rarely you can have something else, but the surgeons are used to seeing these lesions as mostly just myomas and differentiate between the two of them. So, Rajesh, surgical planning, how does this imaging help you? What are the approaches? What do you think you would do? What are the ways to deal with this?
So it is located very close to the G junction, so the resection is not going to be easy. So you can, if you have, say, expert minimally invasive surgeon is there, and quite because you will require quite experience in minimally invasive surgery if you want to deal it with either laparoscopy or say robotic, as compared to a lesion which is located on the greater curvature, which is much easier to tackle. So you may need to do laparoscopic suturing. You should be able to do that because stapled resection is not going to work here. And then you may also need endoscopic, intraoperative endoscopic help to decide whether G junction is narrowed or not. It may help you making suturing without narrowing the G junction, without causing narrowing at the G junction. So all these things have to be kept in mind. And if it is not possible to do it minimally invasive, then open surgery can also be done. And then the idea is to get a margin. So you have to do a wide local excision with a surgical margin is there, and then you close it. That is the basic idea. You don't have to do extirpating surgery like a total gastrectomy. You just have to resect the tumor with the margin, and then you repair the defect, and you make sure that your G junction is not narrowed, and then you add some kind of a fundoplication to cover the suture line as well as to prevent reflux. So
I think that's a key point, Rajesh, you made, that you don't need the same surgery as you do in carcinoma stomach. The radicality can be far lower, and yet you need functional preservation. So those are the key points you made there. This was done. We did a robotic assisted wide local excision of the G junction through a gastrotomy, and then, as you said, the skills work and assist the skills, and you could easily reconstruct the rejunction and then create a fundoplication around it. So neoadjuvant therapy, that should be an interesting bit here. So
before we go to that, did we biopsy this tumor? And should we biopsy this tumor? This particular is a small tumor, so probably that might be.
So great question. So why don't you take that, Vikram, now? Would you want to biopsy this?
Yes, so I think I will definitely go for a cross-section imaging. As Dr. Rajesh said, endoscopic ultrasound in these patients is a selective thing. Most of the patients will end up in a real world getting an endoscopy, And endoscopy, though most of the surgeons will presume this to be a GIST, the next common investigation which will be done will be a CT scan, a cross-sectional imaging, and then probably an endoscopic ultrasound if you think that this lesion deserves a biopsy. For me, if this lesion is more than 5 centimeter, if you're thinking of neoadjuvant therapy, and if you are thinking of uh, uh, then probably I will biopsy it. But a small tumor, less than 3 centimeter, if you're planning for an upfront surgery, probably we may not biopsy that, is what I wanted to
So the
suggest.
key point would be that if you want to operate upfront and do a RZO resection, you need not biopsy it,
Yes,
provided you
but
think you can do a
yes, but your
good surgery.
clinical and clinico-radiological diagnosis of GIST should be nearly confirmed. You should be sure that there is no nodal disease, there are no nodes, there is no visceral metastasis, and this is a clearly you are unlikely to be wrong in your final histopathological diagnosis. Then only you should
Okay.
do that. If you have any
So
doubt,
truly,
probably then
yeah.
are on the side of
So
that.
without a biopsy, Vikram, truly speaking, it's only the US which can tell you which layer it is arising from.
Yes, exactly.
And give you some confirmation short of a biopsy that this is possibly a GIST and you can do a resection there. So what about neoadjuvant therapy in this scenario? It's not a very big tumor. You think it is maybe considered here in a G-junction GIST? Vikram, yes, please.
Yes. So, yes, I think this is a one of the indications for neoadjuvant therapy has been a tumor which is a tricky location like a G junction, where you probably want to offer organ preservation later and maybe avoid a gastrectomy and do something like a wedge or a relatively smaller resection. In those cases, there is a scope that even a large size GIST can reduce to a significant size, and then probably avoiding a gastrectomy is may be feasible in few cases. That may not be always achieved, but that may be feasible. But in this particular case, if you ask me, around 3 centimeter size lesion on the scopy or endoscopic ultrasound, probably not a candidate for neoadjuvant therapy for me.
So I think we'll ask Satya evidence for neoadjuvant therapy. What is the ground reality?
So for GIST, in general, we do not have a very robust phase 3 randomized trial that supports the role of neoadjuvant. Because it has recently come up, like Sir told, for the critical location like rectum, primary, duodenum, G junction, or maybe a case where there is high risk of tumor rupture. Then probably if there is a oligometastatic disease, you want to operate upon if there is good response. So these are some scenarios where, based upon some case series, case reports, and two phase 2 prospective trials, one was from RTOG and another was a Korean trial. So there is some degree of benefit. But some key things to remember here while using a neoadjuvant approach here. One is it is not going to occur at a very rapid pace. It's sometimes the median time to response is at around 28 to 32 weeks. So you have to wait for that period. And if it is progressing before that, then definitely it comes into the primary resistance and all. And also you have to remember, if you are getting a good response, you should not keep on giving neoadjuvant therapy for more than 12 months, because beyond that, some studies are showing decrement in survival. So these are the two things that you should keep in mind whenever you are using neoadjuvant TKI.
So great. I think so. We'll go finish this case and then take it forward. So histopathology. This is the histopathology. Neeraj, you want to say something about this? Neeraj, are you around?
I'll unmute myself. Yeah. So this case was a gastric GIST located in the stomach, and size was like 5 centimeters. IHC has already been done, and this is positive for CD34, dog 1, and this.
So when you do a histopathology, what are you looking for in the histopathology reporting?
Yeah. So basically, I can move to the next slide. Can I move to, yeah. So in a report of GIST, we need to include all these parameters. We have the site there, we have the tumor size, the tumor is unifocal, and we already know that the mucosa was normal. There were no lymph nodes. IHC has been given that this is dog 1 and c-KIT positive. So the mitotic rate is also given. So these are the parameters which should be included in minimum in the report of GIST. And if available, the neoadjuvant therapy and the molecular mutation.
Okay, great. So, how would you decide about? I think I'll leave this part alone. Adjuvant therapy. So, resection done already, Satya.
We need only 2 things, like size and the mitotic rate, and we just have what is low in stomach is moderate in intestine, and what is moderate in stomach is high in intestine. So the intestine gets one stage upgraded.
Okay, great. So, Satya, would you take this? How do you decide adjuvant therapy? So, this was a small lesion, agreed, and the pathology is reported in front of you. How would you decide for adjuvant therapy in such a case, this or similar case?
So, I look at the two things. One is the clinico-pathological factors: the size, the mitotic rate, the location, and if there is rupture or not, and also the mutation profiling. So, these are the two things that we take into consideration for the to decide whether to give adjuvant or not.
Okay, so this is less than 5 centimeters stomach. So mitotic index is very low. So the whole risk is probably low. You want to give adjuvant for this patient?
No, sir. No, I think the patient is in the low to very low risk group. So I think for this particular patient, we can avoid. We have the series of trials for the adjuvant TKIs. Starting in, I think it was the ECOSOC trial that basically approved the role of imatinib at around 2008 or something. Initially, those were approved for more than 3 centimeter, but they have not defined actually it is benefiting which subgroup or for how much duration we should give. Then came the EORTC trial that compared 2 years of imatinib with observation. Again, there was a benefit in a particular subset only, and the benefit was for the imatinib failure-free survival. There was no OS benefit. The OS benefit and basically the current treatment paradigm that we are following is based on the Scandinavian Sarcoma Group 18 study that basically compared imatinib 1 year versus 3 years, and they took intermediate and the high risk groups, and also the KIT as well as the PDGFR mutation. Both they have included. So in this study, it was shown that whenever you are giving for a longer period of time, the benefit is more, and the benefit is for a high risk subset based upon the clinico-pathological factors that I uttered earlier. So this
you would need mutation panel for all this, correct?
Yes, definitely, sir. So, like I told, these trials have included the KIT and PDGFR mutations only, not the wild type or the quad negative GIST. And now there is further advancement to this with the IMAT-GIST and the Scandinavian Sarcoma 22 trial, which is now further trying to increase the duration of imatinib from 3 years to 5 to 6 years. The rationale behind this is the TKI imatinib is not actually preventing the recurrence, but it is delaying because it is somewhat cytostatic rather than cytotoxic.
Okay,
but in
maybe
a practical guideline, sorry, Dr. Rajesh, a practical guideline as of today, when a patient comes after surgery to you, an intermediate risk patient with a gastric primary and a high risk patient with a gastric primary, what is your decision to offer? How many years you want to offer? That's probably what you should tell the
So in my practice, for intermediate risk, I usually stop at 3 years. For high risk, my preference is to continue till 5 years if the patient is tolerating well. So so here the key factor is after 3 years. So between 3 to 5 years, my concern is more toward the tolerance. If the patient is tolerating well, I would like to give the extended benefit of giving a prolonged duration.
So for all practical purposes, intermediate risk is 3 years now, and high risk should be 5 years if the patient is tolerating. Dr. Rajneesh, we usually don't discuss the surgical aspects, we know, but a lot of delegates are asking about it. So probably we will have to go back. I know Dr. Rajesh is going to touch upon that in the next case again.
Yeah, so I think what we'll do is we're running short of time then. We need to cover a whole lot of things. Maybe question and answer is the right time to take those questions.
Yes. And I think that time we will also cover because the first case is the case where there is a scope for endoscopic excision also. So this is the case where your endoscopy is because we are discussing an MDT. So if a gastroenterologist is there, endophytic lesion which is up to 3 centimeter, if he is a skillful gastroenterologist, he's going to argue for an endoscopic excision also. And that probably this probably is also a patient. If it is a 3 centimeter or 2 centimeter GIST, endophytic lesion, and easy one, if your gastroenterologist is skillful, probably he will request you for a ESD. So that is a theoretical indication. Practically, I don't know how many centers offer.
So maybe we can ask Rajesh in the question answer session about what are the reasons for this. Maybe for the completion's sake, Dr. Neeraj, could you give us an idea what mutation panel are we looking for? This is a question which surgeons are very ignorant about. How do you go about how the mutation analysis?
Yeah, so we know that we have the most common genes, the KIT and PDGFRA. If I can go to the next slide. where we have given the frequency. So if we see this pie chart, we can see that the KIT exon 11 of KIT covers almost 65 to 70% of the mutations. So this is the most common exon to be tested. And then comes the exon, the KIT exon 9. And this PDGFR is another 10%. So all this, it covers almost 80 to 85, which is SDH deficient. So for that SDH, we have an IHC. Now you can see that another 1 or 2% will be BRAF, but then there are 1% those tests which do not show any mutation, and they can be very rare ones, like showing RAS or NTRK or NF1, all those. So these are very uncommon, very rare mutations for which we need to go to NGS. So if we move on to the next slide, where this is an approach, because since KIT and PDGFR are the most common mutations, and in that too, in KIT we need to test for 11 and 9 first, not those ones which are either less sensitive or they are secondary mutations like 13, 14 and 17, 18. So we need to test first KIT exon 11 and KIT exon 9 and PDGFRA. If it is gastric cyst and if the patient is young or female, we can go for an SDH immunohistochemistry at the same time and see whether it is SDH deficient or not. If those cases which are wild type, like KIT and PTGFRA, again there we can do SDH immunohistochemistry. And if it is deficient, because here SDH is a tumor suppressor gene, so its loss is important for us, not the expression. So if there is SDH deficiency, loss of expression, then we can go for the germline mutations and try to see if the patient fits into any of these syndromic or the familial cysts. Even if it is negative, then there are almost 3% of those wild type cysts which have those uncommon rare mutations like FGFR, NTRK3, and also there we can go for an NGS. So this should be.
So Neeraj, can you summarize just summarize in one line, what is the first line of tests you need to do, and then beyond that, what can be done?
Yeah. First line, KIT exon 11 and 9 and PDGFR exon 18. These 3 exons and 2 genes. Then the fourth one, SDH immunohistochemistry. After that, BRAF. If you don't find anything till that stage, then you can go for an NGS to cover the rare mutations.
Okay, great. So I think that's a key message. We all run for NGS and want to cover the entire genome because of partly ignorance and partly, availability. So first thing to do is do some key genes, and that will cover most of the cases. And then you have a small numbers left, which can be later on assessed by specialized people. Correct? So let's go to the second case. Kush, can you please continue?
Yes, sir. So we have a 38-year-old lady presenting with dull aching epigastric pains in 6 months with few small bouts of hematemesis since the past 2 months. On examination, she was pale with stable vitals, and abdominal examination revealed a vague lump in the epigastrium. She was evaluated outside with an ultrasound which revealed a 12 cross 8 centimeter lesion, which was partly cystic, partly solid, and had closed planes abutting the pancreas and greater curvature mark. The origin could not be delineated. Subsequently, an upper GI endoscopy revealed a globular mass arising from the greater curvature of the stomach, particularly the mid-body, around 5 centimeters in size. And biopsy was not taken, but clinical impression was just. The CT scan is up for discussion.
So Manish, can you take on the CT scan? This seems to have a lot of findings, and sometimes surgeons find it difficult to. I'll just walk you through it then. Manish, are you wrong?
As we saw in the first case, it was a typical image. And when we go for the second image, we can see that it's large. So in the large lesion, the homogeneous enhancement is gone. Central area of necrosis are there. And you can see there is inhomogeneity around the lesion also. There may be some areas which may be showing the internal areas of bleeding also, and heterogeneous enhancement because of some nodularities. But again, if you characteristically see, the lymph nodes are absent and there is no metastatic lesion in the liver. So it is exophytic lesion, large exophytic lesion arising from the stomach, and it is very close to the pancreas also, and it is also abutting some bowel loops.
So what do you do of CT diagnosis?
Some free fluid?
Yeah, some free fluid, I can see that.
Fluid is there, mild fluid is there.
Yeah.
Again, it is in the favor of just only. The size is large, so it is showing atypical features.
So, yeah, please.
The patient presented to us with Malina for 2, and she had an HB drop to 4 grams percent, and she received 4 of PRBCs outside. She was tachycardic on presentation, and the abdomen again showed a vague lump. Again, the hemoglobin is reflected here. Even after 3 transfusions, her hemoglobin was around 8, and we evaluated her with a PET scan subsequently.
Great. Thank you so much. Manish, let's go over what a PET scan does in a patient of GIST. What do you think? You want to first read the PET and then comment on it, or we'll go downwards? Manish?
Okay, so the PET scan is done with the help of, this is the most commonest PET CT, which is actually FDG PET CT, is a glucose analog. So it is just to show the metabolism of the glucose. We can say that it is more or less related to the tumor growth and metabolism. So whatever areas which are actually hypermetabolic or they are proliferating much will show the uptake. So more uptake, more will be color. This is the commonest thing. Here we can see that this is largely the large mass only has peripheral area of faint uptake, and entire inside thing is more or less necrotic. So this is more or less equal to the CT scan. Nothing is being added by the CT scan. If we go for, in general, the baseline staging and initial risk stratification by using FDG PET CT, so it is technically not mandatory in every GIST cases and it should not be used. It's basically complementary but not a replacement imaging modality of CT scan. So it should be done if it is very large heterogeneous masses, which are actually, when biopsy is very risky and non-diagnostic, and even the CT scan is being confused. But it has some potential for showing the your prognostic marker. So the more or less SUV, if it is more than 5, then it is strongly correlated with the high mitotic index and Ki67 and even the NIH high risk markers. And even new studies are showing that if the MTV means metabolic tumor volume, you just want to see how much volume of metabolism is there and total size of the lesion and the SUV max. They show the total lesion glycolysis. They are also considered to be metabolic marker. But otherwise, until unless you are going for the neoadjuvant therapy, there is no indication for doing PET CT in every cases of GIST at the baseline.
So when you do a PET and then you want to reassess, where would you put PET? So reassessment of after neoadjuvant therapy, where would PET and how do you do it, if at all?
PET CT has been standardized actually for imatinib only. For the imatinib, various studies say it says it can be done after 1 to 4 weeks, but more or less it should be done after 3 to 4 weeks. And the strict criteria is there is a fall in SUV max of around 25 to 40%, or there is absolute SUV max which is around less than 3.5 or 3. This is the most important criteria. It is almost 90% sensitive, 90% specific to show that it will be responding to imatinib for long term. But if it is not responding till the 3 months, then it is high probability that this particular GIST is having resistance for the imatinib, and you should go for further molecular to know what kind of mutation it is having.
So Manish, if I were to just be provocative and ask you, can you replace mutation and just do a PET scan, give imatinib, do a PET scan and see response? Is that a valid approach?
If the primary lesion, if it is very small in size and it is showing very high SUV, may say around 10, 11, 12, something like that, I think then you should go for the molecular, even the first go, because you never know, okay, what is happening inside. And if there are multiple areas of metastasis, then you should go for the biopsy and molecular from the side which is showing highest uptake.
Okay, I think that's a valid thing. Vikram, you want to comment on this? People
Yes,
want to replace mutations
actual,
and give PET scans.
Unlikely to replace, but I think as Dr. Manish suggested, actual utility of detecting an additional MET by a PET is not there. It actually just tells you about the SUV uptake and probably the functional nature of the tumor. It is not generally going to give you an additional MET in a liver or a lung or anywhere. So that utility is not there for PET. But if you are not doing NGS, or if you are not done this test, this is the fastest way of knowing a response to the neoadjuvant therapy or to the systemic therapy which you're going to start. But again, in real life, that use is not done. Nobody repeats a PET scan in 7 days. But if you do it at baseline, then only it makes sense to do it again after 4 months or 3 months when you're giving an imatinib with neoadjuvant intent, or even in a palliative patient to reassess.
So that question, Manish, we'll get you to that question again. If you haven't done a baseline, how do you assess response with the PET? We'll come to another case and ask that question again to you. So meanwhile, we got a PET scan done. This was a report. Patient is bleeding. otherwise fit, operate neoadjuvant. Rajesh, your vote would be?
So if the patient was not bleeding, then obviously such a large lesion and there is chance that spleen and pancreas may be involved, so it may require a multi-vessel resection. So in that case, the choice I'll tilt towards neoadjuvant. But because the patient is bleeding and required 7 transfusions, so in our center, the protocol is if somebody is requiring more than 6 transfusions, then they deserve surgery. So here, my preferred choice would be to go for surgery because patient is having such potential bleeding.
I think the bottom line would be that if the surgeons feel that if he thinks he can get away with the R0 resection, then he should operate, at least in a patient where an option on neoadjuvant is available, and then you can take it forward. So,
because R0 is possible in this patient, at most it will require a distal pancreatic osteotomy with the wedge of stomach.
Might require.
That is what it is seen on the PET scan and the CT scan. So you can do a R0, but it will be a much bigger surgery than just a wedge dissection.
Yeah.
Generally, the greater curvature just appear more ghastly than they are actually.
Yes, I was about to point out the same thing.
Yes, they give you an appearance that they're going to mesocolon, they're going to pancreas. But more often than not, you don't need a colectomy or a pancreatic capsule shave at the most, and even the spleen can be spared. But yes, spleen, diaphragm, colon, pancreas, everything may be required, but less often than what we think.
The sheer size, and this is an important message here, sheer size of a gastric gist around the greater curvature makes it appear like infiltrating or at least abutting very important organs and might require a multivessel resection. By and large, in most cases, the surgeon can get an R0 resection with just a sleeve gastrectomy. But of course, this is open to interpretation of a CT scan and confidence of the surgeon. So this was the pathology. Neeraj, you want to comment on, we are talking about the diagnosis and the risk stratification here.
Yeah, I think here again, this is the cell is the epithelioid type and the mucosa is normal. Mitosis is again in the below less than 5 cutoff group. And the IHC is positive for it is diagnostic. DOG1 and CD117 both are positive. So immunohistochemically and morph again it is just size here it is given 10, but I think earlier it was 12 or more than 10 centimeters, 12 centimeters something. So it falls into the intermediate group, and it is a gastric gist. If it would have been the intestinal gist, it would have been in the higher risk group.
Would you count this? Sorry, sir. Would you count this patient into a high risk group because there was probably some rupture or spillage?
Yeah.
There was a bleed.
Rupture. If it is a rupture, then it will upgrade. Yes.
Yes. And before we go on to that, Dr. Rajni, yesterday we discussed that we will entertain the idea of probably non-conservative measures if this was not bleeding so severely. So I think some of the delegates have that question. So if the hemoglobin, so they replaced almost 5 patch cells, and in spite of that, the hemoglobin again was 4 or 5, and over a period of a month, the patient's hemoglobin has not gone up. So I think there is enough evidence that this is a major episode of bleeding, and this patient probably will not tolerate neoadjuvant, and probably surgery is justified in this case. But if you get a chronic bleed where the hemoglobin is maybe 7, 8, and after replacement it normalizes, that patient may be a good candidate for neoadjuvant imatinib with this kind of tumor, because the tumor handling probably improves after neoadjuvant.
Yeah. So what we're looking at is a bleed over what period of time? So bleed over 5 patch cells transfused over 1 week versus over 3 months or 4 months is a different scenario completely. So yes, neoadjuvant therapy and response has a potential to stop at least chronic slow blood loss, but not acute major blood loss.
Endoscopy gave us an idea about this patient, that this patient will not require more than a gastric wedge as far as the gastrectomy is concerned. So I think a surgery was not a bad choice in this patient, or maybe in fact a good choice.
So Satya, we have a tumor here, you have the report here. What do you think about adjuvant therapy given the background evidence you had, and how do you work on this?
Sir, risk stratification wise, this patient definitely needs an adjuvant therapy, but like what dose to give, what drug to give, for that I need the mutation analysis. So I think the epithelioid, it was an epithelioid histology, right? So in general, they say in the epithelioid histology in the gastric area, they are saying, means the literatures are saying these are KIT negative and PDGFR positive. So I have to see if it's the PDGFR D842V mutation or non D842V mutation, and then accordingly I will decide what drug to give.
So I think the key message here would be that do not start adjuvant therapy without at least a basic panel of mutation, which Dr. Neeraj had suggested should involve c-KIT 11 and 9 and PDGFRA, and if possible, if these are wild type, then maybe a SDH and BRAF should be done. Dr. Neeraj, you want to add anything here?
Yeah, I think because it is epithyroid morphology, so PDGFRA mutation are associated more with epithyroid morphology, but it is not the case that KIT will be negative. So if we go by the frequency wise, we should do KIT first and KIT and PDGFRA both. So both should be done, not only PDGFRA.
Okay,
Practically,
great.
madam, but you are going to do both when you are going to do that.
Yes,
So
yes,
her sequencing will involve both. Practically, you are going to, in all these patients where analysis is required, you are going to do a KIT, PDGFRA, SDH by immunohistochemistry, and probably this is the basic panel which we will do in all patients where some form of imatinib is required or a systemic therapy is required.
I think most teams follow this approach. We also follow this approach. So basically, mutation should involve a basic panel of 11 and 9 c-KIT mutations and a PDGFRA. SDH, we usually reserve for the second line if these are wild type, and then move forward to SDH and BRAF. So case 3, Dr. Kush, would you like to present here and then we move forward?
Yes, sir. So we have a 50 had an appendectomy 20 years back, presented with chief complaints of hematochezia since the past 3 months associated with postural symptoms and pain in the lower abdomen. On digital rectal examination, had a 2 centimeter mass palpable from the inverge with regular mucosa. She was admitted outside, evaluated with a colonoscopy and biopsy, which revealed a spindle cell type GIST with a moderate proliferation index, underwent outside, and was started on imatinib based on the current histopathology report available.
So the interesting part is that the fellow started, and this is the usual norm in most cities in the country or centers in the country, they would start imatinib without getting a mutation panel. And the patient had a diagnosis because of a biopsy report, which had a GIST. This is easily done. Now, mutation panels are usually not done in most places, or at least they're not aware of getting them done. So most patients are started on imatinib. So patient presented to us like this. Please continue.
So in 2 months of help, she continued to bleed and ultimately was referred to a center. On examination, she was pale, was tachycardic, abdomen showed a stoma, which was healthy, functional, but digital rectal examination again showed a large mass with regular mucosa.
Okay.
Hemoglobin 6.5 after multiple transfusions. The rest of the blood panel was normal. And the outside biopsy was confirmed in the center, which again showed a GIST with moderate proliferation index. And we evaluated with the PET scan subsequently.
So this is interesting. Now, what do we do? Dr. Manish, once you go over this, then we'll take it to the clinicians as to what they want. Would you want to read these, please? Manish?
Yes, sir.
I'll let it run on its own then.
Go down, go down.
You can forward it midway. The thoracic cuts are repeated.
The most important thing is that already we have given 2 months of imatinib. So we are expecting that if the lesions are there, they should not be avid. But we can clearly see there are multiple lesions in the liver, the right, left as well as right lobe. Most of them are enhancing as well as FDG avid. So this is metastatic, and there is no actually residual disease in the abdomen.
So there is a pelvic lesion. Let me just come to that.
Large pelvic mass, which is almost encasing this pelvic cavity, and
it's highly avid, isn't it?
yes, it is very, very avid.
Okay, so let me take that to our clinicians. Diagnosed case of large rectal GIST, things which are already available with us with multiple liver metastases, all of which are avid, has been taking imatinib without any mutation panel for 2 months and continues to have PR bleed. So, Rajesh, Vikram, what would you think? And we'll get Satya also into the picture.
So since we're dealing with metastatic disease here, sir, so we need a mutation analysis to see, and it has not responded to 2 months of imatinib because you can see enhancement on PET scan. and bleeding has also not stopped. So probably it is resistance, primary resistance to imatinib. So we need to have the mutation analysis. Secondly, if we can maintain the patient on blood transfusion, then and, we can get the time to do this mutation analysis. But if the patient is bleeding and not giving that time, then we may think of intervention radiology to get the embolization of the feeding vessel or localized radiotherapy. These are also the options.
So, Vikram, you want to add something here? Your approach?
I know. So I agree with Dr. Rajesh. This is a metastatic disease. My aim would be to go towards systemic therapy as much as possible, imatinib or whatever is indicated. If bleeding is a major concern, I will make every effort to treat this with conservative measures like angioembolization, whether it is internal iliac or whether it is IMA, it will be determined by the angio. But we'll make an effort to stop this bleeding with non-surgical measures. And if they fail, then only probably a rescue surgery may be considered. But yes, I will agree with Dr. Rajesh that I will try to treat this conservatively and then probably get back to the systemic therapy as early as possible.
Okay, so I'll take Satya's opinion. Sorry, please continue.
And if surgery is indicated, again, probably I will look at what is the lower extent of the tumor on PR and sigmoidoscopy. Sigmoidoscopy is difficult, but at least proctoscopy. So rectal preservation is what I would like to do, but I know it's a very large tumor, and I think we'll get the further information from you.
I think the PR was 1.5 centimeters from the anal word, so unlikely that you can preserve the rectum and the anal canal. So I'll take Satya's opinion here. I know mutation is not available here. Any idea blindly increasing the dose of imatinib or adding sunitinib would take care of any of this? Because it's a big tumor, you can see. And IR and radiotherapy often are not available to surgeons sitting in tier 2 cities.
So if you ask me, ideally, I think both a change in the systemic therapy based upon the mutation analysis, especially an NGS at this setting. And I will tell you why I want an NGS for this patient. And also I want a local therapy either in the form of either surgical intervention for the bleeding tumor, because none of my TKIs are going to give a magical response within days. So that is going to take some time. And if you have, let's say, if you have given imatinib 400 mg, then it pretty much covers your standard KIT exon 11 mutation. It will cover your non-D842V EDGFRA mutations. So only thing that is left is if it is a KIT exon 9 mutation. Then in that scenario, this high dose imatinib may help. But we have seen even if it is exon 9 mutation, would have been some degree of response. But in this patient, I have seen no clinical response. So for systemic therapy, I definitely need an NGS, which is going to take some time. And in the meantime, I would like to get a surgical opinion or a IR opinion for the bleeding tumor.
Okay, great. I think the important thing is that mutation analysis takes time. Aside from the time the drug itself will take for causing hemostasis. So sometimes the surgeon does not have that kind of a liberty or time. And in this case, apparently the surgical team decided that we can do a resection because the other options are not clearly accessible to us. So emergency APR with the resection of the gist was done. And luckily the surgeon could get away with the R0 resection, at least local tumor. Obviously, there's still liver metastasis to be dealt with. So, Neeraj, you want to comment on the histopathology?
So this is spindle cell gist, and again the size is more than 5 centimeters, but mitosis is less. So it comes into the high risk group because this is a rectal gist.
Yeah, so one thing is that it's already metastatic.
Margins are
two, this rectal gist, so both things make it a very high risk gist. Aside from the mitotic index and the size, these two are very bad prognostic factors. So, treatment of metastatic gist. So I think, Satya, you already told us you wanted a mutation panel. So here's a mutation panel which Dr. Neeraj lab did. So would you want to comment on this, Neeraj? This is the panel you wanted in the beginning, correct?
We did. Yes, we did for these three common exons, EDGFR 18, CKIT 9 and 11. And because all these were negative, so we, because SDH immunohistochemistry was not available, we also did BRAF, a real-time PCR here, but then this tumor was also negative for BRAF. So ideally, SDH IHC would have been done after this. But then if all these are negative, this is an ideal candidate for
So,
doing an NGS.
Neeraj, could you kind of, for the surgeons, tell what is Sanger sequencing, what is NGS, cost-wise different, time-wise difference? How does it vary, and what should a surgeon be asking for?
Sir, Sanger sequencing is for few mutations and few genes. If we have to test multiple genes, we have to go for to NGS. NGS cost-wise, it will be at least 1.5 times more, 1.5 times to 2 times more than a Sanger sequencing. Sanger sequencing is good for the only few mutations like 11 and 9 if we have to do. If we want to do all 4 exons, BRAF, SDH, and other rare mutations, it's better to go to the NGS.
Okay,
and SDH is an immunohistochemistry. So that can be done by immunohistochemistry.
So, sorry to interrupt, sir. I had just
Yeah.
one question to Neeraj, ma'am. Ma'am, for these cases I'm seeing, in some of the reports, they have reported as per 10 high power field. In some, they have
Yes.
reported as 20 high power field. So as my understanding goes, I think the reporting
Yeah.
should be based on 50 high power field, which is equivalent to more than 5 mm square. Am I right? So does this make a difference in actually assessing the mitotic rate?
Yes, ideally it is 5 millimeter square area. So if you go by 5 millimeter square area, 10 mitosis or 5 mitosis per 5 millimeter square area. So that 5 millimeter per square area is equivalent to nearly 20 high power fields, that is 40x fields, because different microscopes have a different focal area. So it should be ideally 20, not 50.
So I agree, Satya. We also have been kind of brought up with the idea of 50 high power fields, and gradually I realized that it depends on the microscope also. I think the area is more important than the number of high power fields. Is that what you want to say, Neeraj?
Yes, sir, because different manufacturer microscopes, they have a different field at the same magnification. So a 40x magnification of a good branded microscope will have a larger area as compared to the local smaller manufacturers.
Yes. But
So
you
we
convert
have to
it
go
to
by the
50
area.
or whatever risk stratification you're using for risk stratification finally.
Yes.
Important is
Right.
that sometimes in publications, in the risk stratification tables, they do not use the millimeter square, they just use high power fields, and sometimes it's 50, sometimes 20, and it's very confusing for the surgeons.
So
So
that
here
is
is
why
the clarity.
yeah, 5 millimeter square area, it nearly equals to high power fields at 40x. High power is 40x magnification. So
Thank you.
we should
Great. Thanks
see
a lot.
20,
Thank you, madam.
25.
So we have this. We have a patient who's wild type. Satya, you want to take this? Satya and Neeraj, both NGS or multiple liver mets are still there. They need treatment. What do we do? This was the panel which Neeraj wanted should be assessed beyond
Yeah.
CKIT 11.9 and PDGFRA.
So it again depends on the facility and the affordability. If you have the services available, you can go for because this is a metastatic gist, you can go for NGS, and already 11 and 9 has been done.
So I think message for the surgeons is that just giving blind imatinib is not a good idea, and especially when you have mutation panel which is showing a wild type, giving the drug in the absence of anything else still is not a good idea. So NGS, which, when, how, any idea you want to comment on this quadruple wild type thing?
Yeah, when earlier, like 10 years back, it was only KIT and PDGFRA. They were wild, it was called KIT and PDGFRA wild type. But now we know that there is SDH and BRAF, which can also be done, and it has come into clinical routine practice. So now they say, instead of saying KIT PDGFRA wild type, it is said as quadruple or quintuple wild type. Because now these two genes can be done, SDH, IC can be done, BRAF can be done by simple tests without going to NGS. So after this, if it is a quintuple or quadruple negative, then that case is suitable for NGS, because then you need to study multiple genes, multiple other receptor tyrosine kinases, which is not possible to do by individual PCR Sanger sequencing or real-time PCR.
So yesterday, Satya had asked you a question about cost. I think this is a question which is important for surgeons as well.
Yeah.
So NGS generally costs involved, Sanger sequencing costs involved, tier 1 city, tier 2 cities. What are we looking at?
It all depends on the facilities available with your center and the affordability of the patient, if the patient has to pay.
Satya, you were working in Delhi, so give us an idea.
Sir, in general, like ma'am told, wherever feasible, no logistic constraint, we are going for NGS upfront only. But because, like I told you, there are multiple newer trials that are coming up. that are actually using combo TKIs. Like they are assessing whether it is KIT 11 with KIT 17, 18 co-mutation, whether it is KIT 11 with exon 13, 14 co-mutation. So subsequently, they are trying to give 2 drugs rather than one drug. So keeping that in, although I will also clarify here, all these things are not standard as of now, but these may become the next future therapies for the GIST. Because like you are seeing, we have only imatinib, sunitinib, or regorafenib that is available at a cheaper price. But these are working for a particular subset only. And like you have already exhausted imatinib in this patient, and the patient is still bleeding. Let's say you have operated, but what about the liver mets? If you're not treating it, patient is going to succumb to the liver metastasis. So we need mutation analysis, especially in-depth mutation analysis, those alleles which are occurring at a lower frequencies. These things can be picked up by NGS, so that is why we prefer NGS to do it upfront, because it will be a one-time thing.
Dr. Rajneesh,
Yeah.
I was also going to make the same point. Now you achieved an R0 and you have converted this into a liver-limited disease. And this patient is not having a good mutation, and this patient is unlikely to do well without an aggressive treatment of liver. So I think, yes, we need Dr. Satya and he will need a systemic therapy, but I will keep on treating this liver aggressively. As an exception in this patient, I might consider this patient for a transarterial embolization or even ablation of the liver lesions, because this tumor will progress in liver very soon if he's not going to respond. So anything which can prevent progression of liver disease is to be attempted in this particular patient.
I think that's a valid point, and the next case will probably illustrate exactly the same. That liver-limited disease and a wild type, which is probably resistant to the first line or even second line treatment, and we yet don't have NGS available with us. It is expensive.
If this patient was responding well to imatinib, then I probably would be a little passive and let the medical oncologist just treat that patient, and that patient will do it well for years together. But if this is not a good tumor and not responding to imatinib, then probably role for intervention should be
liver-directed therapy. Correct. Okay.
Yes.
Great. So, Kush, you want to present this? This was the case managed by Vikram's team and long time back. So it has some key messages. We like to present those. Please continue.
So, 32-year-old male presenting a decade back in 2015 with hematomesis in melena since the past 4 months. Evaluated with an upper GI and biopsy, showed a 5 centimeter gastric cyst in the antrum. Underwent an exploratory laparotomy with a distal gastrectomy. Final biopsy again cyst with 30% proliferation index. Mutation panel shows exon 17 heterozygous mutation, wild type for all other KIT mutations. Put on imatinib therapy, 400 milligrams once a day after surgery. Kept on annual follow-up and surveillance.
Yeah. So before you go further, this was Satya, this is good enough. Exon 17 mutation, I think Neeraj yesterday disagreed that this is not a mutation which will respond very well to imatinib, but then that was 10 years back. So what do you think?
Yes, I think I would have done the same only. I had in 2015, we only have this drug for GIST.
Okay, so I think so that point in time, this was the correct decision to make. Patient was on follow-up, and after 3 years, this was the PET scan. Manish, you want to take us through this?
So again, FDG PET CT show actually only 2 lesions in this patient, and there was one actually very small lesion in the segment 3.
Let me show you that. I hope I can take it there.
Yes, it was seen. It was seen. Yes, yes.
Same lesion, another aortocaval node.
Yeah, so that was a little lower down.
Lower down.
And this was the aortocaval node.
Yeah, but it was also missing. So it is most likely, for as far as the PET CT is concerned, both of them should be metastases. But as the lymph nodal metastases are rare in the GIST, so let's see what the biopsy says.
So, I mean, Neeraj, which of these mutations has a predilection for lymph nodal metastasis? I think there's some evidence for that.
So the cases which are SDH positive, SDH loss. So in gastric GISTs with SDH deficient GISTs, they have more chances of lymph node positivity. Otherwise, this KIT 11 and 9, especially if you go for KIT 11, then the codon 557, 558 deletion. That is again met with the worst histological features like lymph node metastasis and the distant metastasis.
And apparently some pediatric GISTs also have lymph node metastasis.
Yes. Especially those with SDH.
Surgeons, because surgeons are generally tuned
and the recurrent GIST.
And of
And
course,
the recurrent
recurrences,
situation.
they can
Yes.
go anywhere.
Yes.
Surgeons are generally tuned to believe that, okay, we can just do a local resection with a margin negative and that should be it. No need for a radical lymphadenectomy. But there are specific subsets where lymphadenectomy may be useful, and this is one of them. So here's the patient. Options. We'll start with Satya. What do you think?
Again, sir, if you are talking as of today, we have to again go back to mutation analysis to check. I'm sorry, for this patient, we have not done the NGS. I think we did a Sanger sequencing, right?
Yes, 10 years back, Sanger sequencing, and we
Yeah,
had
yeah, yeah.
those mutations.
So basically, again, I have to rely on NGS to see if there is any mutation or not. If that is not feasible, then another rational thing to do is to just the dose of imatinib mg or to switch to sunitinib.
Okay, and that would be obviously blind, or you want it after the.
Ideally, I wanted after mutation, but if patient is not affording, then we can just give empirically also.
Rajesh, your opinion. You're a surgeon. You want to operate?
Sir, if medical oncologists want to give some therapy, then I'll happily let them take the patient. But if there's no option, then obviously you can try.
I think it makes sense if the oncologist is confident. Vikram, would you agree? I mean, I know this is your team's work, but given today's
I know.
scenario, you would first give the drug with a mutation panel and then consider surgery, or other way around?
Yes. There are two things. DFI of 3 years for this patient, the solitary lesion in the liver. Unfortunately, there is a confounding factor in the form of paratic lymph node also, and it has a very significant uptake, and I'm sure it was not there previously. So probably either do biopsy from this lesion and prove that this is not a part of GIST, and negative biopsy is not going to help you. So in this situation, probably a surgery would be justified. If it was only a liver lesion, even an ablation would have been justified. But with this node, probably a excision of that lesion, either a wide excision or either a metastatectomy with paratic clearance or a left lateral, whatever is done is justified, is what I would say.
So surgeons are surgeons. I think SDM decided at that point in time we can do a R0, and their team did a left lateral sectionectomy with excision of IAC lymph nodes, and that is histopathology. The liver lesion was metastatic GIST, but the paratic lymph nodes were all negative. So obviously they were
Yes.
inflammatory because of some other reason, and so on and so forth. I'll just complete the patient's presentation and then give you a perspective of what these things are. This is the lymph nodes. Okay. So they did a mutation panel again, as Satya suggested. And remember, probably NGS was not done, not available, whatever reason. This is 2018. And we had now a mutation panel, which is this. We had wild type GIST. And so the team at that point in time stopped imatinib because there was no point continuing imatinib and continued the patient with follow-up. A year later or 6 months later, patient had multiple, again, liver lesions. I'll take the lead here, Manish, and just give them an idea of what. So there were multiple liver lesions, as you can see here. So I think that's the point Vikram made. Do you want to make that point again? Lesions are resistant, so liver-directed therapy. Would you want to comment on this? Vikram, you around?
No, I'm there, but in this patient, I may not argue for that because we have already tried one liver-directed therapy in the form of resection. And
Yeah.
again, this patient has progressed very severely on that therapy. And the current distribution of lesions in the liver does not appear favorable for any liver-directed therapy. So probably my preference now would be to continue a systemic second-line therapy. And now the panel has a different mutation as compared to the primary. So now is the probably a discussion should go towards the imatinib resistance or the change in the mutations over a period of time.
Correct. So we are discussing a patient who's already been managed. I think Satya, you made a point already that you need probably a detailed mutation panel using NGS, and you would have worked on that. And the surgeons today, in today's age, would agree that, okay, but there are still patients who need hybrid management. You can continue the metastatic management by using various liver-directed therapies like embolizations, RFAs.
We have indeed used that in this patient. We have done that, but let's see.
Okay, great. So in the next 3 years, patient did develop multiple hypermontoponic lesions, progressed from one to the other to the third and fourth line therapy. So here's where I will ask my oncologist, Dr. Satya, give us an idea of how does it work, the second line, first line therapy? How do you choose which patients What is resistance, primary, secondary?
Okay, so sir, clinically, we define primary resistance as if, let's say, at a cutoff endpoint of 3 to 6 months, if the patient is not showing any signs of progression, then if the patient is showing signs of progression within the first 3 to 6 months, then we call it as primary resistance. It is usually happening in a small percentage of patients. Secondary is like you will have an initial response or initial stabilization. This TKI is primarily the best response that we get for the initial few months is the stable disease, followed by the partial response. We hardly ever see complete response. So if these things happen after 6 months, then we suspect that there is some additional co-mutation that has developed along the way. So this is how we define clinically.
Okay, so I'll take Neeraj in here and ask her, why does it happen? Why is there primary resistance? Why is there secondary resistance?
Actually, if we have to know the normal physiology for this, what happens, because we know that there is a KIT, there's a transmembrane receptor, and we know that there is a ligand. So whenever the ligand binds the stem cell factor, they dimerize and they just activate their tyrosine kinase enzyme downstream. And these tyrosine kinase residues, they have an affinity for ATP. So this is the normal way how it goes. So whenever there is mutation, if in normal situation, they need the ligand to be activated. When there is mutation in the tyrosine kinase residues, they don't need the ligand, and now they can just get activated on their own, and they keep on sending the signals for proliferation. Now, what happens that and this needs an ATP for function. Now, what happens that in these cases, if there is a mutation in the any of these genes, they will either block, they will compete ATP, which is required, and they compete with the imatinib, because imatinib and ATP both have to bind to the same site. So what happens that this imatinib, it binds in the groove of that as a tyrosine kinase inhibitor, it binds into the KIT this thing groove, and then it inhibits the constitutive action of the this enzyme. So if there is a mutation which either it is competitively inhibiting the imatinib, or it is hindering the conformational structure where the imatinib cannot go and bind, then it causes resistance to the drugs. So you can see that secondary mutations, which generally like exon 13 and 14 or 17, 18, which are very, very rare as a primary mutation, they are more seen in the secondary mutations, because either the conformational structure has been changed, or there is some mutations which are competing with the ATP and not allowing the imatinib to go and bind there and do its function.
Yeah, Satya, would you want to put this in simple words for the surgeons? How would you think what is primary resistance, what is secondary resistance? This is all a lot of jargon to the surgeons, to be honest with you. I mean, in all due respect, these are all molecular hypotheses, but surgeons want to think in very simple terms. So what causes primary resistance? What causes secondary resistance?
Sir, primary resistance can be due to mechanisms like the pathways other than the traditional KIT exon mutations that we see. Because of that, you can have because like you told, many of our practitioners are directly using imatinib without checking a mutation, and we are not seeing a response at 2 to 3 month time, and we are seeing progression of the disease. So that one reason, it could be a non-KIT, non-PDGFR mutation. Another reason, there could be development of co-mutation. Since the time earlier, it could be like exon 17, exon 13 mutation, or it could be a SDH deficient tumor or a BRAF mutated tumor. So simple thing is, if your disease is progressing in the first 3 to 6 months with imatinib, it is primary resistance. If your disease is showing some kind of response and then it is progressing, then it is secondary resistance.
It's essentially a primary non-response and loss of response over a period of time. That is probably the simplified.
Yeah, so the issue really is that, non-response requires imaging, and imaging requires time. So that is 3 to 6 months gone already down the drain. So when do you biopsy it? Is there, as Manish pointed out right in the beginning, the PET scan may give you an idea of lack of response, and you may want to biopsy for another commutation or a resistance earlier. How do you use PET scan, Satya, for picking up primary resistance or secondary resistance?
Sir, in general, we are doing imaging at 3 to 6 monthly interval when we start a patient on imatinib. So not before that.
And so at 3 to 6 months, your PET scan shows still, as you said, less than 50% reduction in SU max. Would you biopsy it?
No, no.
Rebiopsy it.
I just want to rule out progression. That's it. Stable disease is fine enough for me.
Okay. Okay, great. So this is where we are as far as resistance goes. This list comes up in a lot of places as first line, second line, third line treatment. I assume that these are patients where the initial mutation was c-KIT or PDGFRA and was responsive. So how do you switch from, this has been, I find a little difficult to understand, how do you switch from interferon to sunitinib without getting a mutation analysis done? Do you have to get it again, or how do you do it?
So, sir, I think all these trials have developed over a period of decades. So initially, we are not doing the mutation analysis. Imatinib first came into the market, so that's why it became first line. Subsequently, the imatinib progressors were treated with sunitinib versus placebo. So then sunitinib became the second line, and then regorafenib came into the market. So that becomes the third line, and now we have this ripretinib and avapritinib for the specific PDGFRA mutation. So it is related to the introduction of the drug into the market. Like I told earlier also, so now the things are moving with the help of precision medicine, precision oncology. And based upon, like I told you, there are multiple phase 2 or phase 3 trials which are ongoing, which are basically selecting the drugs based upon the complete mutation profiling. For example, if a patient is having with exon 11, if a patient is having exon 13 or 14, then sunitinib is preferred, because it has seen that sunitinib is also blocking the 13, 14 mutation patients. Subsequently, if the patient is having a 17 or 18 mutation, it is shown that ripretinib or regorafenib is doing much well as compared to the other available TKIs. Then for BRAF mutated patients, we have the anti-BRAF inhibitors. For others, or for those who do not have any drugs, clinical trial is actually the standard of care. We have the antibody drug conjugates in pipeline that are basically acting on the KIT overexpression that has been seen in this tumor. So they are developing an antibody drug conjugate which can bind to this KIT receptors which are on the tumor cells. But we have the alkylating agent temozolomide, which is doing some bit of benefit in the SDS deficient tumors. And then we have the cabozantinib, the pazopanib, the in general multi-kinase inhibitors, because they are not only blocking the KIT, they are also blocking PDGFRA, VEGF inhibitions, because it has seen that some of the resistance pathway could be because of the upregulation of the anti-angiogenic pathway. So in those set of tumors, these broad spectrum TKIs are also helping.
So if I were to kind of say that this table is actually useless in the current era, what you need is a mutation panel again after you diagnose secondary resistance on imatinib and also for the next drugs. You can't blindly start one to the other to the third or fourth, correct? Is that the way? Yeah, okay.
Yes.
Because this table is kind of thrown around in a lot of surgical texts, and people use it blindly, even in surgical practice, to start a second line or third line therapy, even without getting mutation analysis done. So I think we'll stop here for the
general progression of second to third line will be same, but irrespective of that, because there is no other option.
Yeah, but
non-response can
what I
be
was trying to
predicted.
what I was trying to say was
Yes.
that when you don't have response on the first line treatment, don't blindly follow the table. Get a mutation analysis
Yes,
done.
exactly.
You know that the table seems to suggest that this is the way to go. 1, 2, 3, 4, 5, and that's the only way to go.
Agreed.
Okay, so Kush, can we go to the fifth case, which is actually a very complicated case, but it has some key messages again.
Yes, sir. So 52-year-old male, no comorbidities, presented with pain in abdomen and distension and generalized weakness and fatigability since 3 months. Next slide. Was evaluated outside with a CT scan and biopsy. The CT showed 2 masses, one from the stomach and one from the small bowel, with multiple peritoneal nodules. The biopsy was suggestive of GIST, and patient was put on lesions. 2 months later down the line, patient presented with acute abdominal distension, 6 gram %. Examination was pale, had tachycardia, received multiple transfusions, and the rest of the blood workup was normal. Even after multiple transfusions, his hemoglobin was 7. Next slide. On presentation, was evaluated with a CT, which showed the following findings.
Okay, Manish, I think you need to take this. This was a really complicated CT. Something a surgeon doesn't want to see. So distended abdomen, low hemoglobin, multiple transfusions given. And we don't know where the primary is.
First thing we can see is there is gross ascites, and ascites is showing hyperdensity. That means it is most likely blood and it is partially absorbed. There is one large mass, heterogeneous mass in the upper abdomen, most probably from the stomach, and another large mass, which is in the lower abdomen. It is very close to the small bowel loops, right side, on the right side. It is showing very heterogeneity, and you can see the layering of the hypertensity. That means it must have bleed. So it shows two masses. The one which has bleed is mostly in the central abdomen, and there is all hemoperitoneum partially absorbed. Again, there is no nodes.
Yeah, so patient presenting to us with a lot of distension, respiratory distress because of the sheer distension, and somebody put in a drain in the emergency and drained 2 liters of hemoperitoneum. The patient continues to be tachycardic with a low hemoglobin. So plan, Vikram, I know there are not too many options. This is a very sad
I
scenario.
know. This patient needs an emergency surgery, probably. Yes. So emergency
Rajesh, you have any
surgery
other ideas?
and whichever tumor is
Yeah.
bleeding needs to come out.
Because the patient is bleeding, sir, emergency surgery is required. So option would be, one would be you can just pack it without doing much dissection. You can get out quickly, and then maybe you can use intervention radiology. But if you find there is a tumor which is ruptured and you can easily get away by small bowel resection, so then partial resection, you don't need to take out everything in the abdomen. Whatever the part is bleeding, you may
So
do
this is
certain,
damage control surgery, as I think you're trying to suggest. So damage
yes.
control surgery really has to be decided on a as is where is basis. You can't predict what you're going to encounter and
Yes.
what will happen. So this is what we did. A large peritoneum was resected, multiple metastatic deposits, primary, possibly stomach, possibly small bowel. Very difficult to say. 2 large masses there resected, and post-operatively patient was still all right in the ICU. Post-op day 5 had a recurrent bleed because again distension and drop of hemoglobin took place. A repeat CT was done which showed hyperdensities in the left iliac fossa and had to be re-explored. So re-explorations for damage control surgery, Vikram, not something a surgeon wants to do, but often is forced to do.
There's no option for, I think. It's a clinical decision, I think, rather than the disease. This is just clinical decision that the patient unstable has to go. We have to go in again.
Yeah. So what I wanted to kind of highlight here was that sometimes we do R2 dissections or debulking dissections in various diseases, not only GIST. And we think it's all right because textbooks seem to give us some numbers. 70% dissection gives you a good outcome, 90% dissection. But there is a price to be paid for that debulking or a damage control surgery. And this is one
I
of
will
the
say I will
prices.
not call this resection R2 at all because this was always going to be a damage control and a palliative surgery for bleeding control. So this probably was never a candidate for surgery. We would not have operated him if he did not
Unless
bleed.
because of bleeding.
Yes,
Agreed.
yes.
Yeah. So was in the ICU for 3 weeks, weaned off, shifted to the ward. And this was the pathology. Neeraj, quickly.
So I think it is size is I think 16 centimeters. It falls in the high risk group.
Yeah, not
And
much to really see. It is high.
Mitosis is also like 6 more than in the 5 more than 5 group cutoff.
I think the point Satya was trying to make again. HPF is 25 here instead of 20. So we keep on looking at different HPFs. I think it depends on the microscope as you suggested.
Yes.
Area is more important. So anyway, so point is it's a high risk GIST. It's a high risk GIST. We know that. And this was a PET scan we managed to do because the patient stabilized. Manish, you want to take this? I know there's not much really. I'll run and let it run. And maybe you can give us an idea of what are we dealing with.
There are actually multiple supraclavicular as well as mediastinal nodes, and pleural effusion. ICU care was long, maybe infective inflammatory also. Apart from that, there is large area of collection and residual masses in the lesser set, as well as there was intense area of FDG detachment, where the previous mass was there. So there is some residual disease. Apart from these inflammatory changes also in the mediastinum and pleural effusion.
You think it was a good idea to do a PET in this patient? I mean, what did you gain? Actually, not a question for you. This should be a question for the surgeons or the oncologist.
If you are looking for a residual disease, then it is okay because you need a baseline scan to just see whether TKI is responding or not. then the baseline, this will become a baseline scan actually.
It's the same
Okay.
patient, and when did we do the scan?
This was after he came out of the ICU.
No, I think wrong time to do a PET probably. So a lot of inflammatory changes. So
Yeah, I agree. I would
yes,
agree with
we
that.
wouldn't have yes.
So it would be better to do mutation analysis, and then if you're planning something, then do a baseline PET before starting the therapy.
Fair. That sounds all right. So options of management. Satya, you can take this from here. I think we've discussed this already, but I would like to hear it again from you. Metastatic, please.
Again, sir, I think we need the genetic sequencing report for this patient.
Okay, so this was the NGS panel which was done for this patient. We had some time on our hands, so we did an NGS, and this was a mutation. You want to comment on the mutation, Satya?
So I said that this is the exact mutation that I was telling earlier also. So the PDGFR, in PDGFR also, we always look whether it is this D842V mutation or a non-D842V mutation. So if you have a non-D8V PDGFR mutation, you can still give imatinib. Imatinib still works there. 400 mg imatinib is sufficient. But for this particular mutation, we have this new drug called avapritinib. But unfortunately, this is not yet available in India. Ideally, the guideline says you can observe these patients. They consider the natural history is relatively indolent. I think you have already done a debulking surgery. So either observation, do nothing. As then when the patient becomes symptomatic, you can start a TKI, possibly a broad spectrum TKI in the form of sunitinib, pazopanib, or cabozantinib.
Okay, is it worth giving anything else apart from avapritinib, or is it kind of just whitewash?
So ideally, they are saying that this D842V mutation, the good thing about this type of patient is they are relatively indolent. There will be disease progression at some point of time, but that is going to take some years as compared to the KIT exon 11 or 9 mutations. They are not as aggressive as the KIT mutations.
And this is one of those.
That is one good thing.
Okay. And just to kind of take it from the last case, Dr. Neeraj, this is one of those mutations which causes primary resistance.
Primary resistant, yes.
Just for the surgeons, we need to keep on rubbing that in.
Yeah.
So
Case
this
6,
particular
Mutation
patient,
analysis is not only.
last thing, in this particular patient, he was put on multikinase inhibitor, but the response will not last longer. The problem is, the good thing about this is an indolent type of lesion. So you already assessed the extent of the tumor in the primary surgery. So after a few months of time, maybe 3, 4, 5, 6 months, this is the patient where probably you can consider a cytoreduction and achieve a CC0 in this patient.
That would depend on how the patient behaves on the therapy.
Yes, exactly. But consideration in the back of the mind needs to be kept in this particular patient.
That's fair. So since we are here, I mean, Satya and Manish wanted to actually discuss this issue. Manish, you want to talk about that metastatic GIST, different mutations and different metastases? That was very interesting that you gave us on a PET scan in a discussion with you.
Whenever you see the heterogeneity of the SUV uptake now, I think that there might be multiple lesions in the liver. Some of them are showing uptake and some of them are not showing uptake. Then always go for a lesion which is showing the most uptake. Because we have seen in many cases, especially we are doing the CA breast now, CA breast and CA lung, that there will be complete response in some, suppose liver lesions or lung lesions, but the lesions will be so much progressive that you just see that there is some different heterogeneity. So I think that those particular lesions which are not actually responding, that should be taken up.
So essentially what you're suggesting is a PET-directed biopsy.
Yes, you can try that.
Okay. Satya, what is your opinion about that? This is something which is coming up in most oncology now very rapidly, PET-directed biopsy.
Yes, sir. Yes. So I think whenever we are in doubt or some dubious cases, so it is always we always take. I don't think, but sir, I just wanted to know, we do not have any particular robust phase 3 data or guidelines to suggest this, but this is more of a practical thing that we are following. Am I correct?
No. There is no guideline as such of now.
Sir, I just wanted to add, we also have another upcoming thing that is the role of liquid biopsy. I think Neeraj ma'am can tell better. So with this liquid biopsies, the tumors that are shredded by this cancer cells into the blood, those can be picked up also. And it has seen that the liquid biopsies, it has made its way into the colon cancer. I think we recently had a ASCO updates about a lot of liquid biopsy getting incorporated in the colon cancer adjuvant setting. So maybe in GIST also, Neeraj ma'am can tell if that can be done, because
it
it
is
can
common in
help
many
us
other
to track the
cancers.
tumor over a period of the natural history of the disease.
Yes, because since it's a non-invasive technique and the same mutation which is tested in the tissue can be tested in the blood. So it is coming up in many cancers, not like colon, lung, and many other
So what is the
gastrointestinal.
status in GIST? Is it available in the market? Do mutation analysis for GIST from blood rather than try to take a biopsy? Because that solves a lot of problems for the surgeons. These are soft tumors, you don't want to poke them.
Yeah. So technology is same. Like if you want to do KIT11 and PDG4, you can go for PCR and Sanger sequencing from the this tissue also, but from the liquid biopsy also. But since these DNAs are very less, we get very small amount of DNA, and in that also the mutant DNA may be further very less. So it's better to go to NGS with liquid biopsy, so where you can test many mutations with a small amount of substrate.
So are there labs in the country doing it for GIST?
Yes. Sir, I think
they must
it's
be doing commercial. You go for a solid tumor panel, which many of the commercial labs are doing, or maybe in some institutions. So you just have to give the sample and they will do from the liquid biopsy. What is done from the solid tissue, that same thing can be done from the liquid biopsy.
Great, thanks a lot.
So the basic funda is, if you're dealing with any solid cancer nowadays and you have exhausted all your lines of therapy, a liquid biopsy as well as a biopsy is approved by FDA. We do a comprehensive NGS in those patients to look for all the genes that is there in the body for tumor agnostic therapy or tissue agnostic therapies. It is recommended for almost all the metastatic solid tumors.
Yeah, there are large panels like 50 gene panels or 100 gene panels. So most commonly these 50 or 70 gene panels are there which cover most of the mutations in the solid tumors. So those are done in these cases, in the liquid biopsies. So you can pick up more than 99% of the mutations if they are there.
Great. I think this much is enough for the surgeons. They can, people who are interested, and go back and read more about the liquid biopsy. We'll just take the last case. Kush, you can just kind of run through the case. And there's some key messages here, which again, different from the others. Please.
Okay, a young lady, 15-year-old, presented with recurrent episodes of dull aching abdominal pain since the past 3 months. Ultrasound showed an exophytic lobulated mass, 3 × 4 centimeters, arising from the pancreatic head and duodenal complex, which is abutting the bile duct. Rest was normal. And was evaluated with the pancreatic protocol CT, which showed interesting findings.
Manish, you want to tell us about this?
The lesion is very interesting. It is different from the other. It is very well enhancing lesion. It is most likely arising from the head of the pancreas or from the exophytic duodenum. Apart from that, you can clearly see there is one lesion in the second part of the duodenum as well as the fourth part of the duodenum. So there are multiple lesions, and contrast enhancement pattern of this near pancreatic lesion and other two duodenal lesions are entirely different. Again, there is no node and no other things. No liver lesions are noted.
So I think I can just kind of point out which ones we are referring to. Let me just see whether we can actually show this multiple lesions.
This is the first lesion.
Now, this was the first lesion. And
another one is
here is another one here somewhere there, is it?
Yes, slightly above, sir.
Slightly above, okay. So essentially the imaging showed us multiple lesions. So please, Kush, please continue.
Yeah. So was subsequently evaluated with an EOSN biopsy, which showed a 2.5 × 2.5 hypoechoic mass arising from the head, and biopsy was suggestive of GIST. The IHC panel is quite confirmatory. And we decided to operate this patient because she was symptomatic and she underwent a Whipple's procedure. And the specimen was again a 4 × 4 centimeter hard nodular mass arising from the D1 with umbilication, and multiple small nodules were felt along the duodenal wall. They were intramural lesions. There was again a small serosal nodule which was seen on the jejunum, which was again consistent with GIST. So it was an oligometastatic tumor with a nodule on the jejunum.
So we should call it multifocal.
Yeah, multifocal.
Multifocal.
Neeraj, you want to comment on this?
Yeah, this is a young female with multifocal GIST, And so we should look for those familial cysts or the pediatric cysts. Like in the intestine, multifocal NF1 mutated cysts are more common. If it would have been gastric cyst, then SDH deficient cysts are more common. But by convention, we should do the KIT and PDGFR because some of these patients may also have germline KIT mutations. So they are the primary familial cysts. So these are the uncommon rare cysts, which are the intestinal ones are positive for NF1 and the gastric for SDH deficiency.
So this case actually was put up to illustrate the fact that uncommonly a very small percentage can have some syndromic association. And these are 4 of the common syndromes, not common really, rare syndromes, but for just these are the ones you should be thinking of. And implications, what would be the implications? I know pathology is not the right person, but have you seen some patients with multifocal cysts or syndromic cysts? Vikram, Rajesh, anybody has seen any?
No, sir.
No.
Okay.
Not much actually.
Yeah, I know it's anyway less than 1% of all the cysts, but occasionally you do encounter pediatric cyst and multifocal cyst. So then you need to go do all this genetic counseling, associated tumors, prognostication, and so on. So the last bit we are done with the cases is something which I wanted Satya and Dr. Neeraj to comment on. This was what I picked up from one of the recent publications. They step beyond the risk stratification criteria that we have been using for almost 20 years, less than 20 years, which was primarily based on size, location, and mitotic index. So, Neeraj, you want to comment? Satya, you want to take this?
At that time, we didn't have so much of mutations. That's why we were following that. But now, since most of these mutations have come up and they have shown that the ones which we morphologically call high grade are not actually high grade, or morphology which we call low grade are not by mutation molecular analysis, they are not low grade. So I think this is a new thing which is coming up. And then
so implication in clinical practice, Satya?
Sir, as of now, none. But yes, I believe in next 5 to 10 years, we will be using all this genomic risk stratification in our day-to-day clinical practice. Because as you can see in this trial, the bar diagrams are clearly showing the basic clinico-pathological characteristics. That was the initial risk stratification based one was from the pre-imatinib era. Now, with this, all the neo TKIs being development, with the toxicity, it's not that we have not discussed the toxicities of TKI, but these TKIs have chronic side effects that can seriously cause a decrement in the quality of life. So you can see in the bar diagram also with this genomic risk stratification, there has been in 30% of cases, there has been an upstage from low risk to high risk, and there has been a 50 to 60% of downstaging from high risk to low risk. So a lot of patients can avoid this TKIs based upon this genomic risk stratification if and when it is validated.
Okay, great. Since you touched that question, I would, sorry, Neeraj, you want to say something?
Yeah, because this will need NGS always to classify molecularly. So I think still it is not very important because most of the centers even don't do the basic panel, the minimum panel. So if we need to have NGS in almost all the cases to upgrade it.
Yeah, Neeraj, we are trying to hammer that message down the throat of surgeon and through this VTV that basic mutation panel, please get it done before embarking on giving imatinib therapy. So, I mean, Satya, this last comment from you, problems with imatinib therapy in terms of tolerance. What do we need to monitor, and how long can those problems have happen, and what do we do about them?
So,
tolerance.
The most common side effects that we have seen is anemia, periorbital edema, or this nausea that is there. Because these are very nagging side effects. These are not very serious. A person will not come to OPD, but this will nag the patient. So there are some tips to it. Like, for example, if our patient is experiencing nausea with imatinib, especially in the initial 1 to 2 months, you can just divide the doses. Like if you are giving 400 mg, you can give it in a BD dosing. If there is periorbital edema that is creeping in, you can always give him or her some diuretics. So if you are doing this symptomatic management along with imatinib, then patient will be on treatment. Because again, an important message from my side, I will again say these are only cytostatic. once you stop the drug, it has seen the disease is going to come back and come back at a rapid pace. So it is very important that the patient needs to be compliant on imatinib, especially in metastatic GIST cases. Because I have seen in my clinical practice where we have stopped for some reasons or on patient request, and when the patient came back to us without any follow-up, they defaulted in between. When they came to us, they presented with bulkier tumors and with possibly more emergence of resistant mutation on this subset of patients. So it is seen, unlike other tumors, I always say for this patient, they need to be on close follow-up, because if you detect them early, they can be detected at an asymptomatic stage and imatinib can do well. But if you're not able to detect them at an earlier stage, then we may miss out on a certain number of patients.
Do we need to monitor blood parameters of some kind on imatinib therapy?
Yes, the standard CBC, KFT, LFT, and electrolytes level.
Right. So I think, Vikram, we are done with the cases. Let's go to the chat box.
Yeah.
Do you want to take the chat box?
Yes, I think the most of the questions are, sir, in the meeting chat only, because most of them are on the faculty link. So you
Doesn't
just
matter.
go to
Please
the
go ahead.
meeting.
I think, why don't you
Yes,
go ahead
yes,
with the chat box here?
I'll go there. So one of the earlier tumor was close to GE junction, and one of the delegates is asking if it requires a proximal gastrectomy, would you consider interposition of a jejunal limb? I think Dr. Rajesh or Dr. Rajneesh, would you
Rajesh, you
like to
want to take
answer?
that?
Yes, sir. So these are all the options. Reconstruction, you can choose what to do because you don't want to do a very major surgery. You don't want to do a total gastrectomy. Even proximal gastrectomy would not be required in most of these cases, especially for small lesions. So you just need to resect with a margin. You just need to resect the wedge, and then you suture the defect, and somehow you uh, try to manage the G junction so that it is not narrowed, either by placing a bougie inside and you suture over a bougie. That is one option. Or you can have intraoperative endoscopy to help you to see that there is no narrowing. And then if you have damaged the G junction area, there is every chance that patient is going to develop reflux. So you want to prevent that also by doing maybe adding a fundoplication. So proximal
Yes.
gastrectomy would not be required. But if it is required, then obviously either you do a esophagogastric anastomosis with a fundoplication, which is all around the lower end of esophagus, or you do interposition with general.
Yes. So these patients are likely to survive longer. If your proximal gastrectomy is required to technically resect the tumor, putting an interposition jejunum is not a bad idea. In fact, it's a very good idea because functional things are going to be very common after proximal gastrectomy. Next question is, why not ESD for the first lesion, sir? I think we answered that time, but why not endoscopic submucosal dissection for the first lesion?
So endoscopic submucosal dissection may not be enough for a GIST because it usually arises in the muscularis propria. Some of the lesions can arise in the third layer, that is the muscularis mucosa or the submucosa. In those cases, ESD may be enough, but you will require more than ESD endoscopic. Sometimes it is called endoscopic full thickness resection. So endoscopists can do that, but obviously ESD will not be useful for majority of the patients. So you will require more than ESD. If you have a
Yes.
endoscopist, you can do endoscopic full thickness resection, but there is every chance of perforation, and then you may need to salvage the situation in that case. But
I'd
obviously, if
like
you
to
have
sound a word of caution, which Rajesh is making. Do not perforate this tumor. It immediately worsens the prognosis by several fold. In fact, one of the parameters in the NIH risk stratification is a tumor rupture. And most of these tumor ruptures are not spontaneous, they are surgical. So that is why doing endoscopic ESD and rupturing the tumor or having a positive margin is a very, very bad idea. So I think, Rajesh, you're hammering that point very well, that if you want to be
Yes,
guided therapy, it is
exactly.
full thickness resection, not a submucosal dissection.
Another issue is the standard resection criteria for them is less than 3 centimeter, but the tumor which is more than 2 and between centimeter, of course, the spillage or the rupture is not acceptable, but removing that tumor in toto through that esophagus, and probably we are putting the patient at risk. So, a very exceptional situation for small tumor, probably if you have a really expert team, maybe the idea can be entertained, but generally speaking, a simple laparoscopic excision or a
Yeah,
canal-based
because but
excision.
even otherwise, even endoscopists, when they deal with the tumor in the esophagus versus the tumor at G junction, the criteria change dramatically. The G
Agree.
junction is a very
Agree.
different ballgame for endoscopists than the esophagus body itself. Please
And
continue.
for us surgeons, now that we are discussing the technique, I think as the tumor starts to go proximally, even towards the fundus or near the G junction, and particularly along the lesser curvature, we need to be very careful because general tendency among the surgeons is to underestimate this disease, underestimate its location. They feel that I will just go laparoscopically and cut the wedge of the stomach and come out. But as the tumor goes proximally, and if the lesion is more than 5 centimeters, you should be very careful. Be very careful in stapling near the esophagus. Do not mix the stapling and suturing. If at all required, even consider proximal gastrectomy, but do a safe resection rather than putting a patient at risk, is what I would say. And do not underestimate the tumor, which is at the lesser curvature. Some of these patients are feasible for transgastric approach, and you should be aware of these approaches if you're dealing with these patients. Anything else you want to add on technique, Dr. Rajneesh or Dr.
Yeah,
Rajesh?
just one question, that endoscopy guidance, that point which Vikram is making, is very difficult to actually estimate from outside, from the serosal aspect, as to where you want to cut when you have fat creeping all over the lesser curvature. So endoscopy guidance would help a lot. So
Yes,
that
yes.
perspective, I fully agree. Please continue.
Yeah, I think the role of intraoperative endoscopy is we covered a little bit. Robotic approach, I think that was an answer. The role of interposition is covered. PET to distinguish from lymphoma, I think we discussed the role of PET.
Manish, you want to comment on
criteria.
this? Can we separate lymphoma? It's not a very nice question, but it is there, so we have to answer it.
No, we cannot. If this is primary NHL of the stomach, we cannot differentiate between the NHL of the stomach and just.
It's not a job of a PET to distinguish between the pathologies.
Exactly.
You'll need a biopsy.
The question is flawed, actually, but okay, fair enough.
Yes. Choi criteria, any words want to take, madam?
Yes, I think so. Manish, you want to comment on this?
Sir, basically, it is just to see the response by the CT criteria. If the contrast enhancement is decreasing and the size is decreasing, based on both. But now it is, if the PET is being used, then it is less and less being used. So there may be, the most important thing is if the PET CT in 10 to 15% of the patients, in the starting, the GIST may be FDG negative. So in those particular cases, don't use PET CT in the follow-up also.
So now again the questions are, yes, Kush, go ahead.
Pose a question. That's the size criteria is partly flawed, don't you think? Because imatinib, when it induces necrosis, the size of the tumor might actually increase, but the enhancement part of the tumor or the avidity on the PET may actually go down.
This happens. Size is not a very important
criteria. Size is not a very robust criteria to be.
Because they are static. These drugs are static, actually. So size will be decreasing gradually, but the enhancement at the FDG will be reducing very early.
But this is just a transient phase of early a month or two. Eventually, generally the neoadjuvant therapy or the immunotherapy lasts for 4, 6, 8, 9 months. And in these cases, you want to see a size response, and most of the times the responder will have a tumor volume response also. Yes. Any role of embolization of actively bleeding GIST? I think we discussed that, but Dr. Rajneesh, anything you want to add to that?
Yeah, I just wanted to add, it is bandied around a lot that embolize this, use IR. Let's just remember these tumors are supplied by several vessels. It's not as easy to embolize one vessel and get a hemostatic area, and we need a person who's very good in the job he's doing. Not every center has a person. Not every patient has a single vessel which you embolize and the bleeding will stop. So before you use that option, please hold on for a while and see whether you can have some alternative approaches. Of course, it is an option available to you, but it is not a gold standard of stopping bleeding in a GIST, whether stomach or rectum.
Yes,
I think it will be more important for the non-stomach GIST, where IR may be helpful. In stomach GIST, it will be very less helpful because stomach has blood supply from so many areas. But in other areas, it may be beneficial to do IR.
But I think I would desist to use it in a small world GIST in those patients, particular resection where we prefer. So ultimately,
obviously, if it is
cases
resectable, then if we are talking about somewhere which it is not resectable, or you want to give new
any
adjuvant.
role of SBRT in oligometastatic disease in liver and node radiation. See, I think these are exceptional therapy. This is not a standard of care as far as the liver direct therapy for GIST is concerned. It's probably more for locally advanced or hepatocellular carcinoma or cholangiocarcinomas. But I don't think there is any great literature on SBRT for GIST. The other liver-directed modalities like embolization or ablation may be preferred modalities. But as the size of the lesion increases beyond the embolization limits, then probably somebody can argue for that. But I don't think there is a great evidence to suggest that it should be done as a priority or a preferred modality. But I
I
think
think we can safely conclude that systemic therapy, if possible and sensitive, is the way to go, whether
so
it is
probably
liver,
they are
whether somewhere
asking
else.
in addition to systemic therapy. SBRT will
Yeah,
not replace the system. Yes.
fair enough. Fair enough. So
Dr. Puneet Dhar is asking there are, I don't know, sorry.
go ahead, please.
Duodenal lesions in second part of duodenum, should they undergo neoadjuvant therapy or upfront surgery?
I think we had tried to address this. Satya and Vikram had taken this. There is no level 1 evidence to suggest which patients should undergo neoadjuvant therapy. By and large, it's an MDT decision. The advantages would be one, you can better undergo R0 resection. You can reduce the scale of surgery. Now, which patients and when would need to be taken up on a case basis. It will be very difficult to say do this or do that in this given scenario. What would your approach be, Rajesh, Vikram? I don't know.
My take would be if even after if the location is such that even after neoadjuvant you still require a Whipple, then you do Whipples primarily. But if you can get away without a Whipples by doing neoadjuvant, location is such that you may get away with the wedge dissection. So it may be worthwhile to give neoadjuvant those cases, especially so if tumor is locating, say, third part of the duodenum, and it is a large lesion.
My experience with duodenopancreatic cyst is they don't do well as well as even if you do them R0 and if it is a large size lesion, even your Whipple is going to ease out if you can reduce their size. So if it is a large size lesion, do consider for neoadjuvant therapy and then probably operate. But their responses, particularly in duodenopancreatic cyst, are poor.
There's a question here about will pre-op core biopsy from a small ball just upstage the tumor? In general, GIST should not be biopsied transperitoneally. They should be biopsied endoluminally. If you are doing a transperitoneal biopsy, you are going to have a risk of either rupturing the tumor or spilling the tumor. So it's a bad
In a
idea.
non-metastatic small bowel lesion should be biopsied. Even for lymphomas, the treatment for small bowel lymphoma is resection. Unless it is a metastatic setting, then you will target the metastatic site. So it's a hypothetical situation where you're going to target a small bowel lesion.
Yeah. So go ahead, please.
I think the questions are done. For familial GIST, plan for adjuvant therapy depending on largest lesion or warrants lifelong therapy? Question mark. Dr. Satya?
So I think the familial GISTs are majorly KIT and PDGFRA negative. So I don't think we have a direct answer to this. Maybe in upcoming times, or maybe if there is a tumor agnostic therapy, tissue agnostic therapy, as and when needed in metastatic setting, I would continue for lifelong. But for adjuvant setting, no. The patient will be on observation.
Yes, I think another point we discussed a lot of metastatic diseases. There is a peculiar difference in a GIST metastasis which occurs in a setting when you compare with other solid organ metastasis. So if you have a longer DFI or a longer disease-free survival in these patients, you consider them good. But it is not the case in GIST actually. In GIST, probably if they are coming as metachronous diseases, the prognosis is not as good as the patients because the options to treat are very limited and the progression from that side time period is going to be faster than what the patient has enjoyed before. So the metachronous GIST metastasis is slightly different from other solid organs is what I wanted to make a point about.
So the familial part and syndromic part is not only important to treat this patient, but also for two other things. One, you need to counsel the family and possibly do germline testing. And two, if it is syndromic, then you might want to look for other tumors elsewhere in the body, which in case of neurofibromatosis or Carney syndrome, there exist. And you might, even if you cure the GIST, you might have to do something about the other tumors which may determine prognosis in those patients.
Dr. Satya, you can respond. You are unmuted now. There is one more question. For a 20 centimeter GIST arising from stomach, for which a sleeve resection of stomach with splenectomy would suffice, can we proceed with upfront surgery? Do we really need pre-op imatinib? And what are the risks of bleed in 3-month pre-op period?
So Satya wants to take it.
Sir, I don't think so. There is any kind of life-threatening hemorrhage that I have seen with imatinib. But I think regarding the surgical, the ball is in the surgeon's court. If they feel upfront surgery can be done, then why not?
Yeah, we have already discussed that size is not the criteria for rejecting these patients for surgery. If we can get away with R0 resection with say sleeve gastrectomy, then why not? The surgery should be the first option in that.
It is
One
very
of
difficult to
the
interpret in a size which is 20 centimeter tumor that you are going to get away with a wedge only. More often than not, a tumor which is more than 10 centimeter goes for neoadjuvant therapy, unless they are not going to respond well to imatinib, which will be suggested by your baseline evaluation. So a general criteria which we use, and probably Dr. Rajneesh or Dr. Rajesh would add, is if the tumor is more than 10 centimeter, even in the greater curvature of stomach, they would go for that. The planes with the diaphragm, the planes with spleen, they will improve. If splenectomy is indicated, of course, you will add to that, but always ensure that you do R0. The tumor handling after imatinib improves. These tumors are very soft and friable to begin with. Once you give a TKI, the blood supply and the overall tumor becomes firmer. So handling of the tumor also improves after that. So a responder can definitely be given a neoadjuvant therapy is what I would say.
So Vikram, is that all? Any more questions there? Whatever I can see, there are a few more, but I think they are all overlapping.
Yes, I think, and even it's time is 9:17 now, so maybe 5 or 10 minutes. Any last comments, Madam Neeraj Kumari or Satya or Manish, anybody? Maybe last comments can be invited, and Dr. Rajneesh, you can summarize probably. The most important message which we wanted to give is don't underestimate this disease. Most of the times, we surgeons we feel that this is the easy resection and this patient will do well, but the risk of recurrence in these patients is very high. A lot of these patients who don't receive imatinib recur very early, and their chance of at cure is lost. So treat them well, treat them in MDT. Is I would like to say. Dr. Rajneesh, I think we can take on.
Yeah, I think my mic is blown off, so I just kind of, if I'm audible, am I audible?
Yes, sir.
Yes.
Okay, my key takes from this is basically surgeons should be aware of mutations, at least basic mutations, and advise them, because by and large these patients come to the surgeons. You like it or not, the first line of therapy is decided by the surgeons. Although in most oncology it should be MDT team, but just as a tumor which is considered a surgical tumor. So even imatinib, the first line therapy is decided by the surgeons. This resection part is decided by the surgeons. A bleeding tumor, whether surgery or neoadjuvant therapy, is again decided by the surgeons. This is the reality of the management of this across the country. So that is why it's very important to educate the surgical audience about the need for mutation panels and decisions based on mutation panels, and to take on board all the three specialties which co-manage these patients, including nuclear medicine, medical oncology, and pathology, and then take a call on what needs to be done in a given patient. That is why it seemed as if we had put up very complicated cases for the consumption of this audience. But the reason for that was as simple as this, that sometimes you start off in a very simple, straightforward patient and we land up in a mess because we are not aware of the background of the tumor's mutational potentials, what is primary resistance, what is secondary resistance, when to advise biopsies. Because in the real life, most of the decisions are being made by surgeons and not by the oncologist, at least in tier 2, tier 3 cities.
And I must say, Neeraj Madam and Dr. Satya really covered that aspect of mutation analysis just very well. I think our inhibition and ignorance needs to stop as far as the mutation analysis is concerned. This Sanger panel, getting it done is very easy. It is very cheap and cost effective. 95% of the patient's evaluation will be complete with that limited panel, which costs at the most 10,000 or 15,000 at a private hospital. In government institutions, it must be cheaper. And if you're going to give an imatinib therapy for these patients for 3 to 5 years, this mutation analysis is going to cost very, very small amount as compared to what you're ultimately the patient is going to spend for their therapy. So appropriately choosing the therapy is very important.
So any key messages from others? Rajesh, would you want to start, and then we can go to Neeraj and then go to Satya as well, and Manish?
Yes, sir. So, GIST is primarily we see the gastric GIST. So, if the lesion is resectable, then you can go ahead with surgery. But whenever the lesion is large, especially if you can get an endoscopic ultrasound guided biopsy, that should be done, and you do a mutation analysis, and you find something which is responsive to standard therapy, then neoadjuvant is not a bad option, especially if you require a very extirpating surgery, that you require a multivisceral resection or tumor is very large. In those cases, it makes sense to give neoadjuvant therapy, although there's not much evidence to support that. But still, in experience, everybody of us would have seen that the tumor, they shrink really well if they're responsive to imatinib, and then it makes your surgery very easy. So that is, and I'll cite one example. There was a very large, it was around 25 into 30 centimeters, and then it would have required distal pancreatic splenectomy and major gastrectomy. So we gave imatinib for a year, and then the tumor left was only 5 centimeters. So we just needed a simple wedge dissection. So that is the potential of neoadjuvant imatinib is if it works in those patients. But obviously, it has to be done keeping in the mutation in mind, and if it is resistant, then we obviously have to change plan very quickly.
And as surgeons, do not commit or force yourself to do many invasive surgery in these patients if the tumors are large. Doing an R0 resection without tumor rupture and spillage is extremely important. Neeraj, madam, anything to be added from your side?
I think most of the things are covered. You already told that the basic panel should be done. I think if you do just a few PCR sample sequencing, one real time for BRAF and an SDH-IHC, you cover more than 99% of the mutations. So it's only the less than 1% for which you need an NGS. So I think the basic panel should be done in all the cases. If it is inaccessible, you can even go for liquid biopsy if you have the facility and the patient can afford.
Dr. Satya, Dr. Manish?
Sir, I think again, you guys have covered all the things. I think 2 points were left for the neoadjuvant therapy, and I saw one question regarding the time duration between imatinib and surgery. So one important thing is whenever you are giving neoadjuvant therapy, you have to complete the entire 3 years duration of perioperative. It's not like you are given 12 months and you have stopped. So post surgery also, you at least cover, as of now the data is for 3 years, so you at least go for a complete of total of 3 years, including the neoadjuvant thing. So that's one point. Another question was what should be the time interval between imatinib and stopping of imatinib and the surgery? It is usually 1 to 2 weeks, because that is basically the 4 half-lives are
Yes, even a
completed.
week is enough. And in fact, if you don't stop it, that's also fine.
That also works.
We have
Yes.
now stopped demanding to stop it for a longer period of time in our patients at least. But a week is a fair period where they should be off imatinib. I think the one question or one aspect which we missed, Rajnish sir, is the duration of neoadjuvant therapy. I think that was never discussed. So if at all you are going to use a neoadjuvant therapy, what should be the duration of neoadjuvant therapy and what decides that duration? Maybe Dr. Rajesh or Dr. Rajnish, you only can take that as a last surgical question. Probably.
Yeah, I think Satya, you want to take that or should we comment?
Yes, Dr. Satya, probably.
Yeah. So I think ideal is maximum up to 10 to 12 months. The median time to best response is at around 28 to 32 weeks. After 34 weeks, the studies are showing that there is a plateau in the response, but not more than 12 months. Not more than 12 months.
Yes. So exactly. So the good response is achieved at 4 months. After 6 months, it will plateau, and after 9 months, you are just giving it for the sake of giving it. So don't go beyond 9 months. Don't give less than 4 months, and generally 4 to 6 months is the.
A lot would depend also on what was the expectation. What was the expectation of the neoadjuvant therapy? You wanted to reduce it to a duration and not do Whipples versus a GIST which was 5 centimeters. You wanted to just give a few months so that you can preserve the G junction. So expectation is important, but yes, less than 3 to 4 months is useless. Beyond 9 months, one of the reasons people say don't give it for too long is also that you start developing resistance and co-mutations develop, and then you may have a scenario where tumor initially responds and then again becomes worse than what it was originally taken. So usually 6 months is the right time to kind of consider that should I resect this or not. Rajesh, you have any comments?
Yes. So many months, 4 to 6 months. and not more than 1 year by any chance.
One question from my side. Can I ask?
Please.
Is there any role of drug holiday or re-challenging with imatinib? Suppose a patient is showing complete response in setting of metastatic disease to liver.
So Satya wants to take it.
No,
Drug holiday.
No, sir, absolutely no, because I have done it in one of my patient. I think the patient was from SGPJ only during when I was a resident in radiotherapy, and that patient got defaulted, presented to us after 6 months, died within 1 week. And also the literature says also the same thing.
Recurrences come back with vengeance.
Unless and until there is a tolerance issue, the literature is now saying if the patient is not tolerating 400 mg, give 300 mg, give 200 mg, give the least possible dose, but give something. There should be no drug holiday.
In fact, I know of patients who want to take this drug for life because they're afraid that after 3 to 5 years, when you want them to stop, they don't want to stop.
I think most of the things are covered, Dr. Vignesh. We should just close it.
Okay, I think it's time to close. Any key last messages anybody wants to give? I think we've covered most of what surgeons should be aware of. My apologies to the pathologist, oncologist, and nuclear medicine specialists that we kind of stopped you when you could have done much more, because there is a limit to what the surgical mind can take. The idea was to sensitize. Yeah, the idea was to sensitize. Vikram, you can have a laugh now. So sensitize the youngest audience that there is much more to than just operating and giving imatinib, and I think that message was key covered here. So shall we close, guys?
Yes. Finally, the last announcement is next month would be a rectal cancer, most probably a peritoneal disease, surgical management of peritoneal disease for rectal cancer. And Dr. Rohit Mittal will conduct that. We'll identify a team and we'll let you know. But there will be a session next month. And after that, probably JEPNet session will be there. Thanks.
Thank you so much. Have a great evening.
Thank you.
Goodbye.
Thank you, sir. Thank you, sir. Bye.
Thank you. Thank you.
Thank you.